I was treating a patient population that I didn't even know prior to that existed. So I needed to really dig in and figure out how to deliver care for them in the way that they needed to help maintain their dentistry and protect the investment that they made and keep them healthy for the rest of their lives.
No one knows all the answers, but if we can help new graduates to come out and feel more confident than I did coming out of hygiene school, looking at those implants, I think people are going to keep them healthier for a lot longer.
It's okay when you're in private practice to ask these questions. It's okay to go to your dentist and ask those questions and say, hey, you know what? I want to be like a supportive member of your implant care team. And I don't feel like I have enough experience here. How can you help me? How can I learn more? It's okay to be vulnerable and say, I don't know.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 287. My name is Andrew.
And my name is Michelle, the best of the two hygienists here.
Yeah, whatever. Hey, welcome to the student roundtable for this month.
Yeah, it's one that we're going to try out. I think my version of this kind of verses was different than Andrew's.
Surprise,
version.
surprise, right?
I know,
Yeah.
but we'll get it right. So we're trying a new thing with student-focused roundtables where we're going to do something versus something else and just kind of see, is one better than the other, or certain circumstances better than other? I don't know. We're just going to see.
Well, I think what we've learned a lot in dentistry, there's a lot of gray area, and you need to be prepared for every single situation uniquely. And so I think that's why we're trying to give them all of the options.
Yeah, agreed. So we hope you enjoy this episode with Melissa Obrotka and Nicole Fortune. And we love when they're on, and you're going to love this episode. Thanks.
Hey everyone, before we get into the roundtable, I need to give a quick plug for Q Optics. I cannot believe it has been more than a year since Chicago Midwinter of 2020. I remember clearly the day at the conference when we stopped by the Q Optics booth to get measured for loops, and beyond the high quality of their products, I was impressed by their professionalism. If you are a student listening to this podcast or a faculty member looking to help out your students, reach out to our friends over at Q Optics and get them into your program. You have heard on our show many times, we fully support using loupes during clinical care and highly recommend investing in the light as well. You'll be happy with that choice. To find out more and see what else they have in store, check out qoptics.com. That's q-optics.com. And now, back to the show.
Students, we are really excited to do something new. We're going to try out. Andrew and I came up with this idea. We're going to do something versus something in hygiene or dentistry. And today we're going to tackle tooth versus implant, because I know that that's always kind of confusing for people, especially if you're not in a practice that's seeing a lot of implants on a routine basis. And I'll take full credit for this, Andrew. I reached out to two of my favorite implant specialists that, one of the many, but these two are definitely smarty pants. They've been on the podcast before. We have Nicole Fortune and Melissa Obrotka, and I can finally say your name right. I definitely remember when I said it, I was like, Melissa Obrotka, and you sent me, it's Obrotka. And I'm like, thank you.
Funny because I was listening to you guys in my car and I'm like, oh my God, she just name dropped me. Oh my God, she doesn't want to say my name.
That's always the hazard. We want to give people credit, but they're like, oh my gosh, do I have to read a name?
It's also not easy. So, I get it.
So I would love for you guys to introduce yourself and kind of give us a little background about what you've been doing in your hygiene journey. Melissa, since I've already butchered your name once, I'll go ahead and say, take the reins on this.
You got it. So I have been a hygienist for 22 years. That's insane when I say that out loud. I can't believe it. It's gone by in a blink of an eye. I work part-time as a clinical adjunct professor at Bergen Community College, which is my alma mater. I absolutely love being in that environment, helping elevate the students, because I really believe that you guys are the next generation that's going to take our profession to the next level. So I want to prepare you for that. And I want you to go out there and be badass hygienists. And I work clinically 2 days a week. I've kind of transitioned post-pandemic, or because of the pandemic. I was working for almost 2 years shy of a decade in a prosto-perio practice where I really got my implant experience, and I got a lot of that experience from making lots of mistakes with these patients and learning along the way. So that's where I really kind of learned that and dug into that, because I was treating a patient population that I didn't even know prior to that existed. So I needed to really dig in and figure out how to deliver care for them in the way that they needed to help maintain their dentistry and protect the investment that they made and keep them healthy for the rest of their lives. So that's where that came in. Now I'm working in a general practice that is doing implant dentistry, and it's kind of neat because they're kind of just getting started on doing it from surgical to restorative. So it's kind of cool to be a part of that and kind of help put in those maintenance protocols and front load that education before the patient gets into the surgical suite. So it's a new experience for me, but it's a lot of fun. And I love dental hygiene. I love how we can change patients' lives every day and make people healthier, make sick people healthy, help improve their self-esteem. I love everything about what we do.
So true. So true. And Nicole's shaking her head. Yes. Yeah. Nicole, tell us a little bit about you.
Okay. Absolutely. I've been a hygienist for about 20 years as well. My dental journey started as assisting in oral surgery. And when I was there, implants were the very last resort. We went through all sorts of things, including apicoectomies, maybe more than once. And if you were to get an implant, the qualifications were rigorous. Not only did you have to have a really good amount of native bone, but you had to not be a smoker. You had to not be a diabetic, because things weren't quite as predictable at that time. And so off I went to hygiene school by the recommendation of one of the surgeons that I worked with. And I landed in a perio practice because I love the whole surgery, get down and dirty with it aspect. And just in that short amount of time that I was in school, things shifted big time. It seemed like there were more and more companies out there. Implant companies are kind of like car dealerships. There's like 4 or 5, 6 big ones that you know, and then there's hundreds. I think there's over 200 worldwide. And there were many advances on how successful they can be and predictable. They become more predictable in some circumstances. And so what I tell people is that we kind of entered the Oprah stage of dental implants, where you get an implant and you get an implant and you get an implant. And it was interesting because over the course of time, we started to see some of the ramifications of maybe some of those patient choices or recommendations we were making or things that we were not doing. I was fortunate enough to work for a periodontist that allowed me to experiment with different things. So I could take a study and see, is this going to work here? Or I can combine different things and try and see if I can get some resolution there. So I appreciated that. And by the time, in the last few years, I was seeing a lot of the what we call Hail Mary cases, where we're just holding on until we can't hold on. And I was really excited because many of those cases would resolve if I had a good partner in the patient and they followed through and I followed through. And many of them remained healthy for that amount of time rather than sitting and degrading slowly over time with that really slow, low inflammatory response. So I feel like I've seen a whole bunch of change in implant dentistry, from the polish and pray prophy to actually detecting and decontaminating things. And I just love it. It's ever changing. It's going to constantly be changing. And I think that our charge as dental hygienists is to keep ourselves informed and look at studies, look at books, look at practices with a critical eye. Question everything. Why? Why this? Why that? Because no one knows all the answers. But if we can help new graduates to come out and feel more confident than I did coming out of hygiene school, looking at those implants, I think people are going to keep them and going to keep them healthier for a lot longer.
That is the truth. So let's talk about coming out of school, and let's say you never saw an implant while you were in school and now you're going into a private practice. What is your thoughts of comparing assessing a tooth and assessing an implant? What would be the big differences that you would do for each one of those?
Nikki, you want to start that one? We'll tag team it.
Yeah, we can totally tag team it. Do you want to know what we think now, or do you want to know what we thought we knew then?
Let's say now, because we want to make sure that like when they leave, because Lord knows I did all the wrong things too. But now, let's talk now.
Now. So fundamentally, the mindset has to be that we understand that an implant is not a tooth. It is a prosthetic replacement for a tooth. And that is a huge concept. So that means, we need to treat it a little bit differently. And in implant dentistry specifically, we actually have to look harder. I talked about our polish and pray prophies. That's what I did. I didn't want to touch it. I didn't want to scratch it. We were afraid we were going to scratch it. It was going to fall out of the patient's head. That's never happened. But was that, did we draw the line? Do we use the stainless steel instruments? Anyway, I'm going off on a tangent. But in terms of assessing, we have to understand that anything that's happening underneath the gum line around a dental implant is going to be angrier and bigger and more destructive than it's going to be around a natural tooth. And that comes back to the basic anatomy of how the fibers change around a dental implant. Even if there was a tooth there, you're going to lose that nice webbing of various connective tissue fibers that help to protect our underlying bone and our root structures. You don't have that anymore. You have just the circular fiber. So it's a lot more vulnerable to insults, into developing inflammation. And when it does, it just takes off. So when we have an implant, you've never seen it before, we're going to take a look. It is a good idea to assess what the tissue looks like, although the tissue doesn't really tell you the story all the time. But it's a good starting point because perhaps you'll get some clues as to what's happening. And then the very next thing that I would do is I would take and I would palpate the buccal, and then I would palpate the lingual. I do it separately. I know Melissa has a different technique, but essentially similar, where I'm going from the base to the apex of that implant. I'm coming out coronally. And if there's anything brewing, you're going to get some exudate, maybe some bleeding. And you don't move on quite yet because we want to see what's the quality of that. Is it thick and green? Is it light and watery? There's a big difference between there. There are some, if you have a crown on an anterior implant that had to be really seated deeply because you didn't want an aesthetic issue with that crown margin, even if it's perfect, will cause a low grade of irritation that you'll have some cells that are shedding there. And we would expect to see that. So assessing the amount, the color, the consistency of that exudate is your next step. Melissa, you want to go from here? Because I'll just keep going.
Yeah, sure. I'm so glad you talked about that because when I would do that step of palpation and exactly what Nikki had just described, where you have a very deep abutment and a very thick mucosal tunnel of tissue, I would see this milky white secretion and I would lose my mind and go grab my doc right away and be like, oh my gosh, this implant's failing. And after a while, he was like, listen, you don't have to grab me every time you see this. This is what's happening. He explained what Nicole just beautifully had explained with the bacteria in the cells. So that's something that that comes with experience and seeing those different types of cases and seeing the different types, the different placement with implant fixtures as well, and how deep that abutment needs to be. That band of tissue also, it's different quality tissue as well. So, in a single implant, you're hoping to have that nice keratinized, thicker tissue. A lot of times in some of these advanced cases where you have maybe a prosthetic that's removable that's sitting in a bar or possibly a locator attachment, sometimes based on where it was placed, there might not be any keratinized or attached tissue. And that's a total different game changer for that patient and what your maintenance protocol is going to be and what we have to help them need to do at home and what we're doing with them to keep that healthy. So yeah, first thing is really taking a look at that tissue and even taking it back a step further from that when you know that your patient does have an implant, which is a question that we should even be intaking on that medical history form and their dental history form. Just asking them if they have any issues with that too. Do you have an awareness? Do you have any pain? Do you have any discomfort? A lot of times I've noticed with implant patients in the past, they would not describe anything as pain, but they would say something, I'm just aware something's a little off. And that's usually a sign that maybe something is starting to break down. So even taking, those questions, like Nikki said before too, in her introduction, like asking why, always asking why, controlling the conversation with your patient through questions is such a great tip and technique, because they're not going to openly tell you everything, but they don't mean to hide information. So asking a lot of questions, and don't feel pushy that you're doing it. You're just trying to treat them the best way you can. So yeah. So outside of doing that, next step usually would be looking to pick up our periodontal probe. Well, actually,
What? Say it again for the people in the back. Are we probing dental implants?
Probing an implant? Oh my
God.
gosh. There's actually science to back that.
I know. Crazy.
Yeah. So if we're still like moving and looking at tissue, we would actually get our probe out and start assessing in that sense. Do we need to do this differently than natural teeth? Hell yeah, we do. That's the big difference. So can we probe them? Yes. Do we need to do it differently? Absolutely. Do we have to even watch what we're using when we're probing? Yes. That's another thing. Do I love a plastic probe to probe an implant? Every day of the week. My favorite is that Hue 3D color view, because I could just see really well and I can manipulate it. With advanced cases, it's not easy to get that keeping yourself parallel to the long axis of the implant. So having that plastic probe is really helpful. But can you use a metal probe? Yeah, you can. It just should not be it shouldn't be the gradient kind where you have the indentations. It needs to be smooth. And the reason being is that if you pick up bacteria while you're using that probe in other areas, you can then insert it into the area of the implant. So you want to make sure that it's a smooth implant, a smooth probe. But whatever you choose collectively in your practice, everyone needs to use the same. Because if somebody's using a metal and another person's using a plastic, you're not going to get the same measurement. You're not going to be calibrated. And then appointment to appointment, that's going to throw things off when you're in your maintenance phase and looking at the depths that were recorded previously. Because it's not the 1, 2, 3, 4, 5 millimeters that count on an implant. It's really the change in number that's important from appointment to appointment. Because of what Nikki mentioned earlier, having that deeper seated abutment, I've had implants that have had 111 circumferentially all the way around, which are awesome. And then I've had healthy implants that measure 6 around 4s, 5s. As long as there is no separation, as long as there's no bleeding, that's okay. Because again, it's a different typography of tissue and bone around an implant than a natural tooth. So you just really, when you're probing, you want to be looking for a change. You want to obviously be looking for bleeding and separation like we do with natural teeth. And then again, what Nikki said, the consistency, the type of pus or exudate that you're getting upon that. Fun fact, I've been probing adjacent natural teeth and a geyser of pus just flies out of the implant when I'm not even on it. So that's a fun thing too.
Yes.
You're like, oh, we got a problem and I haven't even touched you yet.
It's just so inflamed.
Yeah.
So if I could quickly just interject some of the differences I'm hearing you say between natural teeth and implants. So with our natural teeth, when we're probing, we could be getting, 3, 4, 5. And when we see a 5, then we're like, hey, now hold on, let's see what's happening. But if we're getting a 5 around an implant, it's more about like, did it start at a 5? Because it could have started at a 5 because of the surgical procedure, where it was placed, tissue height, bone height, all that jazz. So no, when we're comparing tooth versus implant, you might get a little more worked up with a 5 around a natural tooth, but it's more about where that 5 started with the implant and has it changed drastically.
Yes. That's why your baseline is so important.
Okay. Sorry. I just wanted to make sure everybody was hearing the differences.
Yeah, definitely.
Okay.
You want to pick it up from there, Nick?
Sure. And, with the probing, pressure is a big difference too. I can't remember what it was. Melissa, is it 0.15, newtons? Is that what that is?
Yes.
But who knows what that is, right? I don't know what that is. So I like to encourage people to let the probe fall where it will fall. So you're basically just putting it underneath the gum line. And then it's almost like you're envisioning a trampoline in that area that's going to actually spring you back up. So you're going very, very delicately so that you don't hit that area. And many times if there's a problem, it's just going to drop right in. As soon as you get in there, it's going to go, and you're going to feel those threads. And now you have no bone where those threads are. So it's not just, it's the depth, it's the pressure, it's what are you feeling? What is the patient feeling? Our exudate, like Melissa said, keratinized tissue. Now, natural teeth can be okay with thin keratinized tissue as long as it doesn't change over time, right? And people have good home care. But it's been shown that you need about 2 millimeters, ideally, around a dental implant to help keep that area from becoming inflamed. The plaque will collect there. It'll start to bleed. Patients will avoid it because it's bleeding. And then they come to see you and it's really a mess. So we've probed, we checked things out. We're going to check for any looseness. I know that sounds kind of wild and crazy, but you can feel for sure if the prosthetic, if the crown, the bridge is loose. So you're going to feel it. I was trained in hygiene school to use one end of my mirror and then a finger on natural teeth. But with implants, I actually use 2 fingers. And in some advanced cases, and Melissa, I don't know if you've experienced this, but, advanced cases where people were super bruxers and that implant was in a terrible position in terms of trauma from occlusion. So there's no inflammation there, but I could feel it pop back and forth, like the implant is loosening up. So that's also important to note. And of course, any patient reaction, they're like, oh, that hurts. That doesn't feel good. What'd you do there? So that's what I would do next. I don't know. Help me out, Melissa. Where do we go next?
Yeah, checking for any looseness is definitely my next step in there. When you have something go on, it could be as simple as the abutment. You have to kind of assess too, like how is the prosthetic retained? Is it screw retained? Is it cement retained? Because those are 2 game changers right there too. A screw retained abutment may come loose, and that could be what's going on. So a patient can come in and really be kind of freaked out that their implant is loose and thinking they're losing the whole implant body or fixture, but it's really just the prosthetic could be loosening. And on some of these more advanced cases where we have bars or locators that are holding in a removable prosthetic, those pieces, they need replacement from time to time. So, I kind of liken that to patients like, hey, it's like the tires on your car. You've taken this in and out, in and out, in and out. It's worn down. They need to be replaced. So sometimes that could be something that they're complaining about, that it's not feeling right, but it's really just a little bit of maintenance that needs to be done on their prosthetic. But yeah, asking those questions are super important because you get a lot of information out of the patients, and it could be sometimes an easier fix than you think or they're thinking. I would also, as Nikki said, I used to check blunt instruments for mobility with implants too, because that's what I was taught in school. Mm-hmm. We really were not taught anything in school. I graduated in 99. I was taught 2 things. Don't probe them and don't scale them unless you have a gold scaler. That's what I was told. Like, who has that?
I had one gold scaler, and I would have fought anyone in that office for a gold scaler.
Part of my assessment too, which is different from natural teeth, is that annual bite weighing. Yeah, we do that for our teeth as well, but also a PA. So we're looking at bone quality, bone health, of course, any bone loss, but you also look for clues to why are you getting that exudate? Is the crown not seated all the way? Is there a gap? There are many different things that can cause these problems, and we're like detectives, really, I think, and that comes into play with implants more than does natural teeth.
So what I'm hearing, and that's such a great point, as far as like being a detective, like we do that with natural teeth, right? Like we're like, what's happening here? Why is it home care? Is it bite, occlusion? What is it, a systemic thing? It just requires some different type of detective work. So it's not really all that scary. It's just a kind of a different way of approaching it.
Absolutely. And unfortunately in academia, we're not there yet with implantology. We don't get that flux of patients openly in the clinic that really have them enough to get that experience that you really need to feel more comfortable treating them. So it's okay when you're in private practice to ask these questions. It's okay to go to your dentist and ask those questions and say, hey, you know what? I want to be like a supportive member of your implant care team. And I don't feel like I have enough experience here. How can you help me? How can I learn more? Like, just, it's okay to be vulnerable and say, I don't know. That's how you're going to learn.
Mm-hmm.
So, don't be afraid to do that. I feel in academia, implantology should be its own course, but I understand the restrictions, especially in a 2-year degree program. I mean, we're having you graduate with enough credits for a bachelor's degree as it is. So like, I get it,
Right.
It's hard to fit another course in the curriculum, but it's really, I mean, this is where we're moving. I mean, we're already here, actually. This patient population is just going to keep getting bigger and bigger. So I think an important thing to do also, just to touch on too, kind of backtracking a little, is to kind of figure out why the patient lost their tooth or multiple teeth to begin with.
Such a good point.
Because this is going to serve you really well when you're in private practice and you're treating patients and you're seeing like doctors wanting to, suggest that treatment, like let's replace this tooth with an implant. Well, we have to sit here and kind of ask why. Is this implant going to be successful if this patient is losing their teeth because of active periodontal disease? If it was a traumatic situation or a failed endo, that's one thing. But like, if we've got a full mouth of rampant perio and we're talking about like, let's go move right into all on 4, or like, say we're doing it all on 4 in the maxillary arch and not the mandibular, that's not ideal when we have active perio going on. We need to set these patients up for success. And if there's, I'm quoting Dr. Peter Fritz, he's an amazing periodontist out in Canada. There should be no implantology without periodontology. I just love that he advocates for that, because I think doctors just get excited to like start doing implants. Like you said, the Oprah of implant dentistry, everybody gets one. And we have to just pump the brakes for a second and be like, wait a second, let's get you healthy first. Let's do this. Let's take a few steps. It's going to take a little bit longer, but let's do our due diligence, get you healthy, and then we're going to set you up for the best success. It's one things I actually love that the practice I'm working with now, the head doctor, he always says, you know what, you got to earn this dentistry. And I'm like, yeah, you got to earn it. Right? Isn't that such an awesome thing to say? Like, you have to earn this. You haven't shown us yet that you can earn this level of dentistry. And I'm like, hell yeah, you're right. That's like, I just love that statement.
Well, and it just calls back to all the things in medicine, right? Like, you can't go and get a quadruple bypass, or like because if you need it, you need it. But knee replacement, like if you are significantly overweight where they feel that the surgery would not actually be successful for you, they're not just like willy-nilly putting in there and going, well, we know we'll see you in 5 years because this isn't going to work. Like, right. No, they're talking about like, let's get you to a manageable weight where we know that this surgery will be successful. And I think that's a brilliant way of operating with implants.
Yeah, it's awesome. Oh, and just to backtrack a little bit, because I've said all on 4 a couple of times, and I know people don't always know what that statement means. So all on 4 is a treatment protocol for implant dentistry when a patient is losing, like they just have a failing dentition and their teeth are not salvageable, and we're looking at a full arch replacement. So it's not just taking teeth out and putting a denture in. It's taking teeth out and positioning implants, at least, usually it's a minimum of 4, sometimes it's more implants, and positioning them in a certain way that we can now anchor a permanent hybrid prosthetic onto that. And it's not removable, it's fixed. And the patient leaves with that dentistry. Usually, there's a lot of pre-planning and a lot of appointments before surgery, but they will leave same day with their prosthetic inserted in their mouth and anchored on these 4 or more implants.
One thing I did want to call back to with probing, and correct me if I'm wrong, because it's been a minute since I've been in the implant research, but I used to say things along the lines, because yes, we do need to make sure we're using a very gentle pressure around these implants, and that the seal is definitely fragile, but not to be so scared of it that you are like, I just don't even want to touch it because I'll ruin it. And I'm like, because they're fragile. These little guys are fragile, but they're not that fragile, or we would have like death by tortilla chip on a regular basis in a mouth, right? Like, they can take some hits and keep on going. However, it is just so important to know that you need to get in there. You might puncture the seal, but it's usually in the presence of inflammation. Has any of that changed, like that you are aware of?
No, I mean, the word on the street is that it will grow, regenerate and heal within a matter of days or weeks. And it's just a matter of the clinician understanding why you're getting some bleeding as well. It's always a why. Like, why is this spot bleeding? Oh, maybe I was being too forceful. Taking a closer look at that.
No, that's great, because I really want to make sure that everyone knows, like, yes, be gentle. Yes, they are different than a natural tooth. Yes, the data that we get from it is a little bit different, but you shouldn't be so scared of it, because I know that's what students, like Melissa, you teach them all the time. Like, they're like, well, I just rather not do anything if I think I'm going to hurt it. I'm like, no. Like, we have to do something. And if you did puncture or push a little too hard, it's not going to kill the implant. Otherwise, strawberry seeds, like I said, would we just be killing these things left and right?
Definitely. And we have to think about what we're suggesting for them for oral hygiene too. Like, if we're telling them to go home and floss, do you think that the way that they're getting the floss between the implant and the gum tissue is any different from, you're probably being more gentle probing than they are jamming a piece of floss in there. So, we want to think about the suggestions that we're making for them at home and really take that into consideration. And sometimes where implants are placed, it's not good. And that could be part of the reason why, the patient could be struggling, you could be struggling. I mean, there are some cases that I've had that I tried to measure with a probe, and I was like 44 millimeters from where the tissue met the implant to the occlusal plane. That's not fun. If it's not fun for me, it's certainly not fun for them. So it's a dexterity issue. It's an adaption issue. There's a lot of different things that can go on, and no two implant patients are the same. So that's the thing too. It gets a little bit easier with the experience, seeing more and more of them, but there's just so many different types of implants and the way they're restored and abutments and, different strategies that nobody's the same.
I think implant dentistry, and actually our piece of it and instructing hygiene, is the most individualistic, like unique treatment plan for each patient. That's how we're really teaching patients to do differently. Because let's be honest, right? For patients without implants or just in general, what do we want them to do? We want them to get an automatic toothbrush, right? Because it does a better job without destroying the gum tissue, and maybe they'll, do more of that. Good brushing, and then floss. And we've always relied on these two things. And that's what we say over and over again. There's so many tools out there that are, far more effective around some of these implants than those two things. And I've actually seen some failures with floss. So if you have a patient sitting down, you're asking them what their home care routine is. If they say that they're flossing around this implant, ask them, is it snagging? Is it a clean, does it break? Because if it does, then maybe we shouldn't be doing that there. We can find another option that won't potentially leave fibers behind that could cause an inflammation. But Melissa's right. Everything has to be kind of tailored to what that patient can do. And that's, I'm totally getting off track here, but that's when hygienists really come in handy with like the planning. Because we know the patient's home care already. We know where they struggle. And I think that when doctors are making these plans, that they're missing a great opportunity if they don't bring their hygienist into that discussion.
Oh, such a good point. So if I could just say, like, when we're thinking teeth versus implants, like, yes, there might be a lot of similarities with the home care tools, but you might have to tailor certain tools to that implant versus a natural tooth. Yeah.
Definitely. And do some research on your own. I mean, I know you're totally like overwhelmed right now in school. So when you've graduated, you've passed your boards and you're just waiting for your license, you're like chomping at the bit to get in there. That's when I would suggest like doing some research on implant dentistry and learning some of the different tools that are out there. There's a lot of different companies out there that make a lot of different things that you just need to have those tools in your own personal toolbox, because like we said, each patient is different and you need to have like a plethora to be able to choose from to help that patient get to a place where they're managing their biofilm at home really well. So you can help be that partner in the longevity of their investment.
And the final point that I would like to make with our tooth versus implant, because I think what we're hearing is we want to control biofilm at home, and that's for reduced inflammation, obviously for longevity of the implant and success, but also because we don't really want to be putting scalers to implants. Am I correct in saying that?
Yeah.
which is a huge difference between a natural tooth and an implant, right?
That's a tangent that I'm going to just go off on if we're entering down this road.
Do it.
So here's my problem with scalers and implants. And coming from a person who is in the midst of designing one, I was legit working on designing an implant scaler. So what we need to know, we know what's out there. Let's take a look first. Like we've had these plastic scalers that are as useful as, I don't want to say expletives, but they're pretty much useless.
Garbage.
They're total garbage. It's like trying to do dental hygiene with a butter knife. It's ridiculous. So those are, just throw them out and put them away. And what we've learned too is that because as the years have gone by, the fixtures, the bodies of implants have changed. And yes, you're not always scaling that, which is awesome. You don't want to be. But if you are, and we have a roughened surface implant, and now you're taking a plastic scaler and going around it, you're leaving those particles in that body. And that's counterproductive. I stopped using, well, I knew it was like, okay, this is a problem. But when I was initially working with this patient population, I was using the Cavitron with the blue plastic cover over it. And I started watching it shred as I was going through and debriding. And I'm like, oh my gosh, how much damage have I just done there? So I'm going with my air water syringe and just trying to flush it out afterwards. So, you again, like I said earlier, you make mistakes and you're trying to help, but you don't know what you don't know. So I put that down and I stopped using it. Then I really moved to, I had at the time my ProfiJet combo, and I learned about glycine powder back in the day, and I put that in my ProfiJet because I was like, well, why not? I'll just put it in here and I'll try it, right? Well, I broke it. So that moved me on. So like what the thing is that with any kind of scaler that we have, a scaler is better than nothing, right? But when we have scalers, they're all designed for natural teeth, and these are not natural teeth. When you have an implant in a posterior position, it's a single cylinder replacing 3 to 4 roots, depending on the position, right? So everything is different about it. So trying to take a scaler that we use that's designed for natural teeth and just make it out of a different material like titanium, it's still not going to adapt great. We're still going to struggle with that. So, and what we also need to know is titanium still can scratch titanium. So we have to be super cautious with even using a scaler around it. So there's different strategies to manage biofilm, especially with implants, where we can safely decontaminate that biofilm and disrupt it without actually touching it. That's where dental hygiene really kind of needs to move, in my opinion, not only with these implant cases, but with a lot of our patients.
And, I would also just like to note that, like, if you are using a scaler on an implant. And Nicole, you have strategically done this through the years, right? Because you're getting in there with a perioscope and like checking, and like if there's cement or if there's something happening, you can be very strategic with it. So it's not like a complete no, never do it, right?
Right. I mean, if you can see what you're doing, especially with an endoscope, that's going to magnify what you're actually seeing. So you think about our loops are like 2 or 3 times. My doctors were 8 and the endoscope was at least 50. So up to 150. So it's going to show you every little piece and where you're at. And that's an interesting thing because that makes me think about another difference between teeth and implants is that with teeth, if we know that we have periodontal involvement, we usually go right to root planing and scaling. And then if that doesn't work, they get some nice cut and sew surgery that works, right? Always works, but nobody wants it. With implants, there is no universally accepted protocol on how to treat them. So Dr. Gianobili at University of Michigan has a very different criteria of what he's going to do and when than Doctors Fromm and Rosen on the East Coast do. And they both work and they both don't work sometimes. So it's an ever evolving science, but I think that sometimes newer hygienists get a little anxious because you just don't know what the patient's next steps are. And that's when you have to, if you're seeing patients like this and you know things are going to have to be done, I think it's time for a staff meeting. It's time to check in and see what everyone thinks and where we're going to go and how we're going to educate these patients and what our next steps are going to be.
Yeah, that's great. And I'm really glad to hear like not too much has changed in my lecture because I talk about that too. I'm glad to hear that. So any final thoughts for our students as far as like again, they might not have seen an implant yet. They might not see one the entire time they're in school, and like they're sitting it down with their patient and like, oh my gosh, they have an implant. Any quick and dirty tips that they can use right there in that moment?
Don't freak out. First off, it'll be okay. Don't freak out. Just remember the key differences, right? An implant is just bone and tissue, right? There's no PDL, there's no fibers, there's nothing protecting it. So just know that and be more gentle and more cognizant in your approach, and know that you really need to look for a lot of clues, because you can be that first responder in picking up something in those initial stages. Because if we can detect it in that mucositis stage, rather than letting it go to full-blown peri-implantitis, then we're going to help our patients get them. We can return them to health from that stage, where once we go from mucositis to peri-implantitis, then we're talking, like Nikki was saying, there's all different types of approaches, and not some of them work in some cases, some of them don't. So we want to protect our patients and try to prevent them from getting to that stage. So if we can recognize that inflammation right there and then, not only will you help save the patient's implant, but you're also going to help save them from the systemic impact that has. And that's huge right there.
Yeah, I would tell people, first of all, don't be afraid. Yes, it's different. Yes, it's an implant. We've all used stainless steel scalers. We've all made mistakes, like we said. And did those patients lose those implants? No, unless they were already going to lose them. And I think our charge as hygienists is to be as effective as possible with causing the least amount of damage. And that's what you go on your hunt with your research and understanding and talking to different companies and maybe, trying to figure out what that's going to mean for you. Definitely glycine, erythritol powders, managed biofilm, those are awesome. So I tell you not to be afraid. And then also trust what you know and trust your intuition, because if you made it through dental hygiene school, you know a hell of a lot more than you think. Oh, excuse me. Sorry. No. You know a heck of a lot more.
I think I said a curse word.
We are not explicit. I'm on this podcast. There's no way we could be explicit. Or what is it? The safe one?
There's a safe curse word?
I don't know if it was a family program. But trust what you know more than you think. And just trust your gut. If you see something doesn't quite look right, it's probably not right. And it's okay to question it. And if you find out it's fine, great. But if you found out if you thought there was something wrong, you had a sense and you ignored it because you were, for whatever reason, you're going to regret that when that patient returns if it really was a problem.
Mm-hmm. Andrew, any final thoughts?
Nope.
Andrew loves when I'm on these and I just talk the whole time and he just learns.
I have all these questions that we didn't get to.
Oh my gosh, I want to hear them.
No, it's okay. Next time, part two on tooth versus implant.
I gave you the opportunity.
No, I know, but it was good. The thing was, it was good. And it wasn't really aligned with where I was going. It was a complete different way of doing it. And I want to stay on track because it was good.
There's so much too. I feel like
because I derail people. I don't want to derail people.
I feel like we didn't even scratch the surface because there's just so much.
I know. There is.
Yeah.
Yeah. So essentially, don't scratch the implants, but also don't be afraid of them. I definitely come at it with curiosity and get the information. I personally, when I was like a babe, a little novice hygienist, I had like a sticky note of like, these are the things that I need to do for the implant. And like, if I didn't see it on a regular basis, I did see it, I would just be like, the grandkids are great. And then like look at my sticky note just to like make sure I remembered everything that I needed to do. So maybe that can help you.
That's a great suggestion.
So, thank you. And I would love for people to be able to learn more from both of you. So please tell everybody where they can, interact with you.
So you can interact with me either through my website, Nicole Fortune, rdh.com, or my email address is nicky.f as in fortune @hotmail.com.
Perfect.
You can find me on Instagram. It's the Badass Hygienist. And send me a DM because I'm actually building and launching a community called Badass Hygiene. And I'm going to have some courses in there on implant maintenance. So hit me up because if you want to be on the email list for the pre-launch, it's coming very soon.
Well, congratulations, because that's not easy to put together. I'm sure it will be amazing.
Thank you. It's been a labor of love for sure.
Yeah, don't we know? We know all about the labor of love. Well, I just want to say thank you to you both for coming on, sharing all your expertise and your knowledge, and to continue to grow our profession and make us all just better clinicians so we can be the best for our patients. So thank you.
Well, thank you guys.
Pleasure.
Yeah. Thank you guys for all you do and raising awareness and helping like every generation in hygiene. Like you guys hit the gamut. So keep kicking ass.
Thank you. Well, another great week, another great episode. We thank you all so much for listening each week. If you haven't already, hit that subscribe button, whatever podcasting app you're using. Also, just a reminder, our guests are so fantastic that they love when you reach out. They love when you interact with them on social media, and you can interact with us on social media as well at Instagram or Facebook. We're also on LinkedIn. You can find us at A Tale of Two Hygienists. You can also go to our website, ataleoftwohygienists.com. And we would love for you to go there and subscribe for our newsletter. We have lots of stuff on our website. We have a learning center. You can search for any episode. This is an easy place for you to find the links for our CE courses and take the test. There's just so much more there. So head over to ataleoftwohygienists.com. And if you want, you can also send us an email. I'm Michelle at ataleoftwohygienists.com. And then there's Andrew, who is Andrew at ataleoftwohygienists.com. And we just want to say thank you so much. If you love this episode and you're loving the podcast, we would love for you to subscribe and leave us a review. And, 5-star, go ahead and do it. 5-star, just hit that 5-star and then leave us a review. We really appreciate it. We love reading them. It fuels our fire. And we just appreciate you guys so much. I think that's it, Andrew. Anything else?
Nope, that's it. Have a good week, everybody.
Bye, y'all.